Hi, my name is Emily Moore, and for my senior change project, I chose nurse to patient ratio. I currently work at Augusta Health in ICU, and I've worked there for almost 2 years. I've been a nurse for close to 5 years, and I started working at Augusta Health on PCU, and I worked there for a few years, and then I took a position in travel nursing, and then I came back and started working again at Augusta Health. For my project, I chose nurse to patient ratio, and the reason why I chose this is because I feel like it's an ongoing issue throughout the United States and frankly throughout the world. Being that I worked on PCU, I was able to see how, in a sense, abused the nurses were with having to take too many patients at a time and how unsafe it was. So I decided to do my project on that because I would be able to research and study a little bit more and find out what the evidence showed that were good policies and bad policies and why. So like I said, nurse to patient ratio is an ongoing issue. It's constantly been the cause of strikes throughout the Union States, constantly been debated legally. It's very hard to get it passed as far as having a specific nurse to patient ratio where it is capped. California is the main state in which a law has been passed, so on their floors like PCU, they have a mandatory nurse to patient ratio of 1:4, so the nurses can have no more than 4 patients. And from the studies that I have read, it has shown that those patients have gotten more efficient, better, and safer care. My Pitcock question is, in patients receiving care by a nurse in the inpatient hospital setting, how does the nurse to patient ratio of 1:6 on PCU compare to the ratio of 1:4 on PCU influence the quality of patient care over the hospital stay? So I put in here on my poster one case study of a patient who ended up dying, and it is very associated with not getting the quality care that he needed to get from his nurses. So it took place in an ICU where that night they had many call outs. So typically in ICU you have a 1-to-2 patient ratio. So the nurse normally will take 2 patients. Occasionally, depending on the acuity of a patient, they may only take 1 patient, and occasionally, especially in the larger teaching level 1, level 2 trauma hospitals, sometimes it is a 2-to-1. So there's actually 2 nurses per patient because that patient is so critical. So in this study, there had been a couple call outs and too many admissions, and I guess the nurses felt like they were able to take another patient because one of the patients, so the nurse had 2 patients, and one of her patients appeared to be very easy as far as complexity, was not very ill, and was almost independent. And so that nurse agreed that she would take another patient, giving her 3 patients. And that night, when she got that other patient, she was in the room doing the admission, taking care of that patient that was more critical. And her other patient that they assumed was not critical ended up going to the bathroom and ended up being found later on the floor and had passed away. And despite their efforts to get the patient back, they weren't able to get them back. So that's just one out of thousands of case studies. So it's hard to say that, is it because of the nurse to patient ratio? Yes, maybe not. It's hard to say exactly. However, what you can say is that when nurses have fewer patients, they're going to be able to give better care, better quality of care, and safer care. So evidence does show that when nurses have fewer patients, the readmission rate for that patient within the next 48 hours significantly decreases. Patients do not fall near as frequently, so they're not hurting themselves as frequently. Pressure ulcers are not as common. Patients that are not able to ambulate or move in the bed themselves are being turned every 2 hours. They're being changed more often, so they're not sitting in their own soil, developing skin issues. Medication errors significantly decrease. The nurse is not as rushed, and she's able to think more thoroughly. Do I want to give this this drug, or do I not want to give this drug? They're able to critically think because they have time to critically think. And then the big thing is that on discharge, when nurses have fewer patients, they are able to spend more time giving more quality discharge instructions. So when the patient goes home, they don't just wing it per se. They're able to go home and know what the signs and symptoms are that they're looking for, such as congestive heart failure. I'm looking to see if I'm gaining weight, a certain amount of poundage within a certain amount of days, because the nurse was able to take time because she had time to give that patient. So because of that, the readmission rates are fewer, and therefore the hospital does not have to pick up more financial expenses due to a readmission within the first 24 or 48 hours of a patient being discharged, along with financially, of course, bed sores if they occur in the hospital. If they weren't documented that they were there before they were admitted, then the hospital has to pick up all the costs for that, and so that decreases as well. So, recommendations are that in ICU, you still keep the average of 2-to-1 patient ratio. Nurse has 2 patients on average, unless, of course, it's a very critical patient. On floors such as PCU, so a step-down unit, progressive care unit, where patients are often have had strokes or seizures, or they've had heart attacks, so they are being monitored constantly on telemetry. The recommended ratio for that is the nurse to have 4 patients per 1 nurse. And then on the medical and surgical floors, where the acuity tends to be less, the nurse has 5 patients. That is the recommendation. To implement that, there would be many stakeholders. The upper management would have to be able to implement those rules, that the nurse is not to take any more patients than what is specified. The manager of the unit would then implement that. Emails would have to go out to tell them what the new rules were. The charge nurses and the people that make the scheduling would have to be aware so they could schedule and assign appropriately. Financially, obviously, that is huge. The hugest issue why they normally don't staff better, because financially a business cannot run if they are not financially savvy. So what would be recommended is if they actually hire travel nurses for 3-month periods, even though they may cost more initially, that would give time to hire more nurses, train more nurses in that 3-month period, and then let them loose and allow there to be more nurses per patient. And then initially it would be more expensive. However, as time went on, readmissions would be less, care would be better, people would be more satisfied, and it just may work out, but it would be something that would have to work its way out. However, in the states that have done that, it appears that it has been beneficial financially and, of course, health-wise for the patients. It would be important to educate why they are doing what they are doing, and then to be able to monitor the outcomes. So send out surveys to patients, have them decide if the care was better this time versus the last time that they were in the hospital, and how the nurses felt as well, and if they felt like the care was better. So that is my Change Project, senior project. Thank you for listening.